Okay, great.
There we go.
All right.
I'm sitting here with the good Dr. Turner, Dr. Duncan Turner.
Hello.
Full disclosure, hello. You are also my doctor. And I love our work we've done as doctor and patient so much.
Oh,
the
good.
people
I'm
need
glad
to
hear that.
know. Yeah, the people need to know the information that's in your brain. So,
All right. I'll empty my brain for you today.
thank you so much. We all
Go
appreciate
all
that.
out. Yeah.
So, you are a GYN. Are you still an OB as well? Do you still deliver babies?
No.
Okay. But by the way, you've delivered a number of my friends' babies. I've come to find out from asking around in these streets.
Yeah. In fact, I've actually employed some of the babies that I delivered.
There you go. Full circle.
Yeah.
That's
exactly.
the true circle of life.
It's the true circle. Yeah.
Okay, so we're here to talk about perimenopause, menopause, hormones, all that good stuff, and I know we're going to get into it. But my first question to you is, give us the Dr. Turner spiel. How did you come to this work? Why is it your passion? Why are you so wonderful at women's health? And I know you work on men as well, but we're focusing on women for the purpose of this interview.
Yeah, because it's more important.
Why do you say that?
Oh, no, it's more important to talk about women than men. That's what I'm saying.
But why?
Oh, why? Well, actually, this is a really important point. Actually, it's because women's health has largely been ignored, and menopause is an example of that. That it's almost a dirty word to talk about menopause, or it was up until a year or two ago. Yeah. And it's really horrific that has been the situation, whereas women have been going through this for millennia, if they live long enough to experience those symptoms. It's really incredible to know that we're getting close to 1 billion women in menopause on the planet.
Whoa.
It's pretty incredible. So my privileges come through deciding that I wanted to do OBGYN because it was a great specialty. I mean, it involves lots of different parts of medicine. It's endocrinology, it's surgery, it's internal medicine, a lot of things that are challenging. And generally, it's a happy specialty. Tragedies do occur, but they're not. We're not dealing with sick people all the time. We're dealing with healthy people all the time, most of the time. And so that was the reason why I got into OBGYN. Another fact is that honestly, women are better patients than men. They want to be listened to, and they actually listen to physicians a lot of the time, or most of the time. So they're good patients to have, and they're happy. The practice of OBGYN for me has changed with time because I've grown older with my patients, and so it was all OB to start with, and then it was minimally invasive surgery. I've sort of made a significant change about every decade in the direction of the practice. So first of all, sort of OB, and then it got into minimally invasive surgery, and then into basically anti-aging, dealing with longevity, and now really focusing on making this time of life as productive as possible for all of us. And so that's how I got to this point. It's my patients have actually led me there. I'd love to say it was all my idea from the beginning. This is what would happen. I wasn't that smart. I just listened to what patients have to say. And so I find myself in the milieu of menopause. And the great thing about that is we just use the term full circle, but that's what it's been, because I'm back in a happy specialty. Because most of the women that I see for hormone replacement therapy who've been in menopause and having other significant issues with their health, we can resolve most of those. And so I end up with happy patients again, which is great. It's really great.
I hope that everybody heard that last sentence. We can resolve. There are answers.
Yeah,
There's a path forward. So I think a lot of people are listening to this because this is definitely my number one question, not just from the women going through it, but the men in their lives as well. They're like, please give me my partner back.
yeah.
So we're going to touch on that. Not touch on that. We're going to get into that later on. But I want to know why, what happened that women's health at this stage in well, actually, sorry, I'm going to ask you why women's health has been ignored for so long, because I'd like you to get into the details of explaining how this travesty happened, but also just for the sake of, so we're all on the same page, when you say being in menopause, are you describing perimenopause, menopause, post, are you lumping it into one, just so that we're all on the same page,
Well,
definition wise?
there is confusion with definition, and
Okay.
various bodies in academia have tried to explain the stages and so on. But honestly, it's a very basic change where a woman's hormones are no longer being produced in the same way,
Right.
and the patient suffers significantly from that change. It's a radical change. It's one of the big. I mean, for women, they're born, they go through puberty, they have children, they go through menopause, they die. It's just
That's the cycle of life. Yeah.
it's the cycle of life, and I think that one of the reasons why women's health is ignored is because women generally are being ignored about all sorts of things. Let's just call it the lack of equality with men in the patriarchal society, that they've not been listened to. And you know, I was my only daughter. I have 5 kids. My last one is a daughter, and she got married a couple of years ago. And I was asked to give a father to bride speech, and also asked by my at that moment future son-in-law for advice that I might have for them as married couple. And it was very simple. It's a listen. Listen. Yeah. You learn much more from listening than from talking, and that's what I've found to be important in my practice. And going back to the question, you said women have not been listened to. You know, it's a woman's hormones in a normal menstrual cycle, in the time of their reproductive years, from the time they go through puberty until menopause, their hormones change by the day.
Yeah.
And that may not seem like a surprise to
to men who live with them.
Yeah. Yeah. But it's huge. And if we take just estrogen, and we're going to be talking a lot about estrogen over the next little while, the levels of estrogen change by 1,000% within a 28-day cycle. They're very low at the time, first few days of a period, and they can increase 10 times to a peak that gets at ovulation, and then it drops down again unless the person gets pregnant, and then it keeps on for a while. But this happens radically every month. At menopause, what happens is suddenly there's a inadequacy of the function of the ovaries to produce estrogen in the same way. And so those peaks go out. The valleys don't actually go. It's all a valley at that point.
It's a trough, a giant trough.
Exactly. So there's very low levels of, there are very low levels of estrogen. Progesterone is non-existent after menopause. And menopause is, to simplify menopause, we'd say that by definition, it's 12 months without a period at a time when there are other circumstances of symptoms. So
Okay.
if somebody could, at the age of 20, stop having periods for some other reason, it wouldn't be menopause.
Right.
Could be in their 30s, because there is something as a ovarian insufficiency, and it has been called primary ovarian failure. They changed the name for the woke word for that is ovarian insufficiency. So that makes it significantly any better. It really doesn't.
It's all the same. It's
It's
the
all
same. It's the same biochemical reaction that's
right.
happening.
So, and this is a huge transition. I mean, the estrogen, it used to be, I think in the 50s or 60s of the last century, it was when estrogen was first become available to patients, and it wasn't a bioidentical, it wasn't what we have now, but it was a form. It was really thought of as the fountain of youth. And then, various studies, misinterpreted studies about hormones and cancer particularly, or complications, changed the picture about 25 years ago.
Right.
And they became really, patients just were frightened to get onto them because everything they were told.
They
And
were scared it would cause breast cancer.
yeah,
Right.
and as we look at those studies before and with a let's say under a microscope, it was misinterpretation. It was ignoring certain features in that study. And we're now coming out of that where we're realizing that there's a huge benefit from hormone replacement therapy. And I will say, and I don't think this is a radical statement at all, but I strongly believe that it's safer for women to be on hormone replacement therapy than not.
The risks, the
General
benefits outweigh the risks.
benefits outweigh the risks. Yeah, absolutely.
Well, it's interesting that you say that because I feel relieved. I'm like, well, I'm glad I came along right at this time because you're right. I feel like in the past, I don't know if it's in the past couple of years, there's just more awareness about it, or if because I'm tuned into it because of what I've been going through. But I just think about the women when that study came, what was it, 2000, 2002, around that area, and the media went crazy with it. I remember that. And I remember thinking, oh, okay, well, we won't do that. And then time cut to now. And I think there's so much misinformation, which is probably why it's the number one question that's asked of me. And I'm like, I can't, I know how to make food. Like, that's what I do. So I need to talk to people like Dr. Turner. So I just think like how much the women who are 20 to 30 years older than I am were robbed of good medicine.
Yes.
And it really pisses me off on their behalf. And in particular, I think of one woman who I'm very close with, who's having just a hell of a time with pain, vaginal atrophy, not being able to pee. Like,
Yeah.
I'm sorry, but women, we pee all the time. And just imagine not being able to pee and how painful that would be. And that's just one example of like a horrific thing. And then nobody talks about it because there's shame surrounding it. Like you said at the beginning.
There's a syndrome called genitourinary syndrome of menopause. It is a collection of symptoms, some or all of which a patient may experience. This only got a name in 2014.
Wow.
Okay.
And that's all the stuff surrounding the atrophy and.
Yeah.
Okay.
That is due almost entirely to lack of estrogen, where the tissues shrink. They lose their blood supply. They lose collagen. They lose fibroblasts. They lose the stuff that makes that work, where it would feel good, and there would be sensitivity, and there would be function. And I've seen patients not being able to have sex for maybe 10 years just because of pain.
Oh,
Now, fortunately,
yeah.
people are getting wise to that and saying, well, there is something you can do about it. The phrase that I used to hear, I don't hear it much anymore, that from patients that would say, well, I just want to go through this naturally. Well, seriously, the natural way to go through this is to die.
Right.
It's part of aging. It's part of a woman's physiology. Giving that figure of approximately 1 billion women in the world suffering from menopausal symptoms, the other way of looking at that is that women will spend more than half their adult life in menopause.
Right. Because we're
And
living longer. Yeah.
yeah, and we're getting close to a time, will it be more than half of their life total, as longevity
Mm-hmm.
increases.
Mm-hmm.
Um, and so this is really, it's a huge issue, and it's not, even by physicians, it's not talked about enough. It's not dealt with enough. That's why, as you graciously came on to our podcast, the Vagina
Mm-hmm.
Podcast,
Mm-hmm.
uh, to discuss all of that. And the reason why we have a podcast is for people to talk about it. And again, thank you for coming on ours, because it was
Of
really
course.
having you there, and I learned
My
a lot.
pleasure. Yeah.
And
Okay. So I want to, and no, this is the exchange of information is very, very crucial. And I know that people are very excited to listen to this episode. And I love it even more when the men write me and they're like, hey, can you interview somebody who can help with something? Because here's the thing. I love Reddit. I'm in the menopause subreddit. I'm in the hysterectomy subreddit. And I got to tell you, because my generation is the generation that started Reddit. So we're already in there. We're talking about everything that's happening. The number of women, it's every day, multiple times a day, women are posting how they went to the doctor and the doctor's like, you should take an antidepressant. You should go on the birth control pill. And I'm not saying that those aren't things that they should do, but I feel like doctors as a whole are still really resistant to hormonal therapy. So I want to start here and ask you, you talked about some of the benefits of estrogen. What else does estrogen perform in the body that we come to miss when it plummets?
let's start from the head down.
Okay.
Just mental function is kept alive and well on estrogen. If one of the frequent symptoms that patients complain of as they go into menopause, perimenopause, menopause, and thereafter, they complain of brain fog, and that's one of the easy symptoms to treat. Um, just moving down spine and heart. The cardiovascular, women have a lower incidence of cardiovascular disease than men up until menopause.
Right.
And at menopause, they start deteriorating more rapidly, and they eventually catch up with men. And in fact, cardiovascular disease, whether it's heart attacks or high blood pressure, strokes, are the leading cause of death for women. So that's a crucial aspect of it. I mentioned the spine, but it's bones throughout the body. The body does well with estrogen. The bones are stronger, and without estrogen, they become softer and weaker. And the huge adverse effect that a spontaneous hip fracture can cause for an individual, is male and female, is immense, because what we know with longevity and what is now referred to as health span of the time of people being older, but being healthy in that older time, not just living longer, they're living a healthy life and they're more active. But they get a fracture and they can't be active for a while. They deteriorate, and it's really hard to get back into that healthy mode, because they've been without exercise. Exercise is a crucial part of treatment of menopause, and actually in terms of increasing the health span of individuals. So the bones are, now we got down as far as the pelvis now, and the real issue is that there are estrogen receptors all over the body. Those are areas where estrogen needs to be, and the body thrives, or that area in the body thrives with exposure to estrogen. So when it doesn't happen, those areas deteriorate. So in the pelvis, there are vaginal mucosa in the uterus, in the vulva, the all sensitive to estrogen and suffer from the lack thereof. So tissue doesn't stretch very more, and that results in pain with intercourse. And you mentioned the bladder,
Right.
difficulty in emptying your bladder after menopause because of the estrogen receptors. They're not getting the estrogen, and they there's a really interesting aspect, I think, to replacement of estrogen for that area, because in a woman's menstrual cycle, as I said, there's this peak of estrogen mid-cycle when that person ovulates, and it seems like the vaginal tissues really need that peak. Now, systemic estrogen replacement will not usually give that peak because we're usually giving a constant, safe dose.
Like the
So,
cream or the patches or the pellets, are you referring
yeah,
to?
all
Okay.
all of those can give a constant and consistent therapeutic level, but often that's not enough of a boost for the vagina. Now, the rest of the body may be doing fine. The brain fog may have gone away. The bones are getting stronger. The cardiovascular disease is getting addressed or not deteriorating or increasing as significantly. But in the pelvis, it seems that area needs a little boost. And so even for people on hormone replacement therapy, they may still have that genitourinary syndrome of menopause of, and going into that in a little more detail, that syndrome is the vaginal pain, vaginal dryness, recurrent vaginal infections, bladder infections, incontinence, frequency of urination, overactive bladder, a whole bunch of bad things
Yeah.
or uncomfortable things, having to get up at night to empty your bladder. Once maybe okay, but two, three,
Multiple
four times
times.
every hour or so, not being able to sit in the car on a long journey for more than a couple of hours, needing to know when you go out where the next bathroom is, because little girls were always told to empty their bladder every time they thought about
That's right.
it. Okay? That was the wrong thing to tell little girls.
Really? Really?
Because holding a urine doesn't make you more likely to get a bladder infection. But emptying your bladder every time you think about it or feel something about it causes you to go frequently. So your bladder never really gets used to expanding. And so
Interesting.
they feel like they need to go all the time. And so that was one of the bad things that those the patriarchs. You better
Yeah.
get in the car, empty your bladder. We're not stopping. So,
Right.
and then the overall, and this is forgotten frequently, is the skin has estrogen receptors.
Oh, wow.
So the skin will age much more rapidly without estrogen.
Mm-hmm.
And it's been great in my practice. We have two plastic surgeons, one of whom looks after faces and skin primarily. That's the focus. And we were talking the other day of how important estrogen is to what she does. And it's so incredibly important. And the medical profession, as I said earlier, I alluded to this, is that even the physicians are not paying enough attention, male and female physicians that are not. I see lots of patients every year because we do hormonal assessments. We reassess where patients are once a year, if not more frequently. And so many times the patients will come to me and say, oh, they had their annual exam with their primary care physician, and he said that, usually a he, but it can be a she, you need to get off those hormones.
Right.
And that's wrong. There is
Tell us why they're wrong, because this is where that people are hearing all sorts of conflicting things.
Okay. There is a very good academic institution called the North American Menopause Society.
NAMS.
Yes, right, that's it. And they made a statement in 2017 that it was safe to be on hormone replacement therapy if you started early enough. Early enough means within 10 years of menopause, that 12-month period of time that without a period. So you are diagnosed, retrospectively, your
I was gonna
diagnosis
say
in menopause.
no until it's been 12 months though, really.
Yeah, but nobody waits that long,
Right.
or at least few people wait that long
Because
before
the
they get
symptoms start
treatment.
years before that happens. So you're
After-
saying as long
right.
as you're
As,
up to that point or 10 years after that point.
yes.
Okay.
Not then or before the age of 60, whichever
Right.
comes sooner. All
Okay.
right. It is safe to do it, providing there aren't any other concerns about breast cancer. Somebody who's already had breast cancer,
Right. Because that can be
particularly
hormonally driven, right? You can
yes,
have a form of breast cancer that is exacerbated by excess hormones, correct?
exactly, or
Okay.
any hormones,
Or any
any
hormones. Okay.
testosterone. Um, so the other thing is that so they made that statement in 2017 that it's safe to be on this, and then they also made the statement that we think people should be on it for the rest of their lives, providing everything else appears equal.
Mhm.
So now, and I remember going to a lecture. Oh gosh, it must be 20 years ago now. There was a visiting professor from Yale who was employed by one of the pharmaceutical companies to talk about the estrogen patch.
Mhm.
And I was, encouraged by the rep here in town to go to the talk. And I thought, no, it's going to be an ivory tower talk. They're just going to say, as little as possible for as short a time as possible. But nevertheless, I decided to go, and this professor just gave such an incredible talk about these things that the North American Menopause Society was saying was okay, and that was obviously before they actually came out with that statement. But it was exactly that's safe. How long can you be on this? And he said, well, my mom's 90 and she's still on a patch.
Love it.
Okay. Now he was a guy who was basically my age. And so it was, I felt validated by that presentation. And it's something that I talk about previously because, as I say, it's safer for most people, it's safer to be on it than not. Now, there are different ways of getting estrogen into the body, and we can talk about that now or
Yeah,
later.
let's do it. Yeah, yeah,
But
yeah,
in,
for sure.
but in terms of all of the bad things can happen, and all the good things that can be avoided or treated by hormone replacement therapy, it's top to tail. It's just
I want to talk. I want to talk about the method of taking the hormones, but I
right.
real quick. You talked about there being estrogen receptors in the skin, and it's funny because at first my brain went to like, oh, you mean outside the skin? But you're talking about deep within the skin, like the replenishment, like the epithelial cells making new skin and
Yeah.
collagen. It's
Yeah.
in there, and so we need that support in order to still have some glowy skin and not just turn
Right.
into an instant wrinkle.
Right. While we think about this, I want to just bring up a point that I really want to make, and that is the pain with intercourse that some people experience, vaginal dryness, vaginal pain. That's the last thing that patients really talk about, and we had to change our new patient intake paperwork to be able to enable that discussion because people weren't mentioning it. It wasn't thought of as a problem. So we changed our paperwork. It said, do you have any pain with intercourse? Just simply, do you have any urinary incontinence? And when that box was checked, that gave me the freedom to talk to the patient about it. Because otherwise, I mean, it's kind of looks, a little weird, this 77-year-old guy asking you about that,
Yeah, yeah,
so I got permission that way to do it.
yeah.
And the reason, so many people stop having sex because it hurts.
Right.
Either it's ED for the guy or it's vaginal dryness for the woman. And that's at least 50% of the population. are having those problems after
Wow.
50. And in 2015, some technology was brought to this country, or actually the technology was already in this country, but it was a what's called a CO2 laser, and was and this is very popular here, very effective. Was in all of the plastic surgeons' offices and in the med spas and so on. And so some Italian physicians thought, well, wait a minute. The problem with the vagina in menopause is lack of blood vessels, lack of collagen. Maybe we could adapt this technology to vaginal treatment. And that was successful. So that's when this technology came to the country, and that's when we began to do what we call vaginal rejuvenation procedures, because we can make those cells better. That mucosa can be better and safer and feel better, and then all we have to do then is to treat the guy, because we've got all the women treated with it.
Well,
So
and I like that you brought that up, because I think that vaginal rejuvenation connotes like the ultimate vanity, like something that only, you know what I mean? Nobody's going to see. Like, I get that you're going to get a facelift, but you're going to get your vag worked on. That's very vain. But what you're saying is like, no, we're actually helping this person still lead a healthy sex life, still
yeah,
feel vibrant, still feel young. And I like that we're kind of redefining that vaginal rejuvenation is not actually
the thought as a
about
kid.
vanity. It's not
Yeah, I mean,
it's not like we're looking at a vagina. We're just trying to function
right.
optimally.
Yeah. Whereas, I think we, the thought of our parents ever having sex was just a horrible,
Yeah, it is
thought,
awful. Yeah.
But we're getting over that now. We've made
Yeah.
things about
Well,
actually
and
having.
also, and dudes can get a pill and have
Yeah,
ED treated, it seems, a
yeah,
lot
yeah.
more easily than we can get our stuff treated.
I've
So,
I've seen so many more male patients now. I'm a gynecologist. My specialty is women's health and pelvic health, and um, I've had a lot of patients ask me if I have somebody to refer their husbands to, because they kind of left him behind. They're ready to go now,
yeah.
and the
Yeah.
husband isn't quite performing the way he used to, and that just dies out when, or that the sexual activity dies out because it's too much
Right.
work, and yet there are lots of things that we can do about it, and I have to mention that almost all of the things we do for males for ED or libido are painless. Okay.
Right.
Going back to the start of this conversation between you and me, why did I go into gynecology in the first place? And it is not only did patients listen and pay more attention to their health, but men are wimps. And so it's very frequent that we want something that doesn't hurt for males. And that's why I made the
Right.
emphasis for all the guys that are listening to this, or the women whose guys have an issue. The treatment that we use for males, although it can sound horrific, like shockwave therapy, and so it's painless. It's literally painless and effective. And hormonal replacement is important for men as well, because they feel stronger, they feel better, they're healthier, usually with testosterone.
Well, and I might want to have a second conversation with you down the line about that, because now because you said it, since the dudes are going to write me saying, "Hey, can you find out more?"
Yeah.
But so let's talk about how, like, we were going to get into, how do you replace the hormones? What are the mechanisms?
One of the things that there are a few cardinal rules. One of them is, if you give estrogen, if the patient has a uterus, they need progesterone as well.
Right.
And in probably in the 70s or so, when 60s and 70s, 60s and 70s, when estrogen first became available, there was a significant increase in uterine cancer. And
Mm.
my roommate at medical school had the brilliant idea of giving progesterone to those patients because in the normal menstrual cycle, they have estrogen. The woman has estrogen all the way through and progesterone for half the time. And then they have a period. So we saw that the average woman didn't get uterine cancer, even though she was having huge amounts of estrogen produced by her body initially. And so he thought, well, why don't we treat these people? Why don't we add progesterone? We'll have them on estrogen, but for 2 weeks out of the month, we'll give them some progesterone. And
Right.
from that increase in uterine cancer that occurred just with estrogen, which is 6 times the normal, if we gave those patients progesterone as well, we put that risk back to less than it would have been with no hormones. So,
Wow.
and that's, as I say, my claim to fame is he was my roommate. So
Nice.
I guess I have more information just by osmosis from him.
Right. Sure.
David Sturdy was his name.
Right place, right time. I love it.
Yeah, absolutely. So, getting into the body, what we have discovered, however, is that one of the cardinal rules is you give progesterone. The other one is, to the greatest extent possible, do this transdermally or not orally.
Okay.
It is more risky to take these hormones by mouth than it is transdermal.
Okay.
So a patch, which is a commonly used method of getting estrogen into the body and getting bioidentical estrogen into the body, it's like the patch sort of acts as an ovary. It secretes this estrogen slowly in a consistent way, getting us to what we've determined to be a safe overall level throughout the month. And some people still use progesterone just half the time. And there are some benefits to that. I mean, there's the overall benefit that you need it, but doing it half the time or all of the time, there's a little controversy as to exactly how you should do it. Progesterone doesn't give us the same options. We don't really have a good bioidentical progesterone patch, but we do have compounded creams which give the estrogen in a very, very the estrogen and progesterone, and for that matter testosterone, in a very safe way. So transdermally is almost a cardinal rule, should be a cardinal rule of hormone replacement therapy.
So when would you do the pellets, or do you not do that anymore? Or are those too
So
much?
we absolutely do those, and
Okay.
that that meets the transdermal requirement.
Okay.
Okay. Now,
It's still
I
time released. Is that the idea behind
no,
that one?
no. Well, yes, they are slowly metabolized
Okay.
by um, by the body, and the reason why I started doing those is that patients were asking for it, and it's a very convenient way. I don't like to start people on that because I never know how well they're going to respond, and how much
Right.
they need.
And completely anecdotally, I remember a friend telling me, "Oh, I tried the pellets and then I bled for 40 days," or something crazy like that. And I was like, "Oh, that sounds terrible." So it scared me to hear that one anecdotal story was in my head, you
Yeah,
know?
30% of women, however they're getting hormone replacement therapy, will have some bleeding at some time.
Mhm.
And it almost always is nuisance value. Okay. The
Okay.
patients need to expect that there's a possibility of that, but they don't want to have it. They're sort of alarmed when they do.
Sure.
And the phrase I hear frequently is people say, well, the only good thing about menopause is I didn't have a period anymore. And
True.
don't do something that's going to be that period back. Well, it doesn't have to be.
Right.
There are a
Because you're
couple of
trying to
ways.
find that spot that that
Right.
you don't have to have the period, but you're
Yeah.
maintained hormonally. Okay.
Yeah. And the pellets are a good way of getting that into the body, but it needs to be it needs to be evaluated. So
Right.
if we put a pellet in for a patient into the subcutaneous areas, usually in the buttocks, um, we'll do a blood test a month later, see what did we achieve? Was it too little, too much? Now we're very cautious because when we put a pellet in, we can't take it out, and it's going to
Right.
last for 3 to 6
It
months.
has to
So,
dissolve.
yeah. So
Right.
the and estrogen and testosterone pellets don't dissolve at the same time. So yeah, it'd be
Mm,
great if everybody got their pellets every 3 months, and that is the way it works for some, but it's not always the case.
right.
So we need to check those levels. So somebody at 3 months who's going along perfectly well doesn't need another pellet necessarily at that time. So we
Okay.
it's all very individually arranged.
So real quick, when do you add testosterone in, or do you always do testosterone?
Don't
And
always
is
do
this
it.
all based on symptoms, blood work, a hybrid of
Yeah.
the two? How do you determine it?
Well, I look at testosterone more as being a supplement as
Mm,
opposed
mhm,
to primary hormone replacement therapy.
right,
Because actually, at menopause, a woman's testosterone goes up a little bit,
right.
and so we're not replacing that because they're already getting it, but they're not getting it high enough to be optimal. And
Okay.
when I mean optimal, we're talking about energy, libido, um, sleep, uh, all those things can help with testosterone. But then there's male pattern baldness that can play in the game with, or hirsutism or acne when
Right.
it comes to the testosterone.
You don't
So
want excess
we don't,
androgen
but we do
symptoms.
want. So it's again a fine line of what's right
Mhm.
for every patient. We're going though. We're aiming for a level of testosterone higher than their body has ever experienced before, because
Oh,
that's when
interesting.
they feel best. But it's
Okay.
not an essential part of hormone replacement therapy. It's a supplement to it.
And by the way, I have friends who've gone through menopause and they don't do any hormone replacement
Right.
and they feel fine. So I guess my
Right.
question for you is, and we'll wrap it up pretty soon here, but my question for you would be, if you're listening right now, what would you, what would you tell the woman listening right now? How do you ask your doctor for this? How do you know if it's right? Do you look at tests? Do you go by symptoms? Do you, because it seems like it's a science but also an art and individualized to every person.
It's very much an art because certainly we haven't talked about perimenopausal, which causes me to be almost bald. Okay, I pull my hair out dealing with perimenopause because it's
Tell us why.
because the ovaries misfire, and you
Mm,
can actually, if you look at it as a double barrel shotgun, sometimes both barrels fire at the same time, and
as
it's
far as
the
ovulation goes?
yes,
Okay.
so there can be one ovulatory cycle going, and then there's something called a loop phenomenon, which happens about a third of the time for women who are uh, just prior to menopause. They're still ovulating most of the time, but sometimes there'll be another ovulation
Pew
occurring
pew.
within a cycle.
Yeah.
Exactly. Okay.
So is
And
this having to do with the FSH being so high right before
yes, absolutely.
menopause occurring? So it's like, just get them out. Just
Yes,
shoot them out
exactly.
like a Pez
Right.
dispenser.
It's called follicle recruiting. So
That sounds nefarious, but okay.
uh, anyway, perimenopause is a difficult one to handle, and it's just something that we just have to take patients along, treat them symptomatically. What is easy to do is to increase vaginal estrogen. The doses that we use vaginally for treatment of the pelvis are about 1% of the doses we use for the whole body. So,
Okay.
but if we get it where it needs to be in the vagina, those symptoms of urinary frequency, urgency, pain with intercourse, dryness, recurrent infections can all be resolved. So it depends on what somebody's symptoms are.
Okay.
The things that I really want to get across is think about this sooner rather than later, because if you go beyond those recommendations of the North American Menopause Society, the recommendations go on because there is increasing risk to start later. That was the problem with the 2002 study. There were patients that were started on it too late, and we're
Too
not doing
late.
that now.
Right. It was quite a geriatric
Yeah,
study group.
yeah,
They
right.
were way past menopause. So
What
what
we
if you're, yeah, go ahead.
what we've discovered is that even those patients that, the people that were in that study have overall decreased or death rate for all causes,
Interesting.
even though they were on hormones that were not bioidentical and things that we generally don't use now.
But that was my
So
question. Can you describe the difference? Because when I hear bioidentical versus synthetic, I'm like, well, they're making it, so aren't they all synthetic? But what's the difference so we can understand how to have this vocabulary?
yeah, again, lots of misunderstanding there. Compounding means a medication that's put together by pharmacists in the lab, and it's allowed by the FDA to do so as long as it's not being produced by a pharmaceutical company as well. Okay. But if it's for the benefit of the patient to do it slightly differently than the pharmaceutical company has done, that's allowed to be the case. What it means is just it's being put together, like the cream that we use for estrogen, testosterone, progesterone is compounded by a compounding pharmacy. You kind of think of, a back room of a pharmacy. The pharmacist back there is with his mortar and pestle, like you would do with your cooking and your herbs and spices, putting this together and being creative. But it's more than that, because bioidentical means, and this is the accurate definition, it's exactly the same chemical and molecule that is in the natural estrogen, progesterone, and testosterone that the woman's body produces.
Okay.
Now, to get that, we don't have a factory of women producing estrogen for us.
Right. How are
that
we
would be
doing
the
those?
ultimate patriarchal.
At the
Okay, you
lady
can go to the
factory.
farm now. You can go to the farm.
Yeah.
So almost all start naturally, meaning that it comes from a plant base. Now, what natural means is hard to say. It's different for everybody.
Right.
But phytoestrogens are taken. Those are plant-based estrogens, and then they are converted chemically to a bioidentical hormone.
Okay.
And then that is available to put in a patch or to put in a cream or to put in a pill. And I'm not talking much about pills, because that's that anything's taken in by the mouth goes through the liver, gets metabolized to an effect, has a potentially negative effect. So we found that estrogen has never been associated with blood clots and breast cancer if it was applied transdermally.
Interesting.
So, the false the confusion is, what is natural? Well, hopefully we're calling natural bioidentical, and a lot of those because the pharmaceutical companies weren't investing any money in producing these chemicals, these hormones, compounding pharmacies were the only people to be able to do it. Then the pharmaceutical companies, big pharma, thought, oh, wait a minute, we can't patent estrogen, so we might as well not mess with it, because there's no money to be made.
Right.
What they did was they patented delivery systems.
Sure.
So all of their research went into the patch. And so, although I'm a great believer in medications that are equal in terms of whether it's a big pharma or now there's a generic, those are all good, and I believe in that. But with the patches aren't generic. They're not all equal. The hormones in them is equal, but the patch isn't necessarily the same. So I like people to be on the same patch month after month after month after month, because they're getting more equivalency. The other thing is that it's not unusual. In fact, it's very common for women to need more estrogen as time goes on, because the estrogen that gets produced by indirectly from the adrenal glands producing testosterone getting converted to estrogen. And so that slows time. It's not like the ovaries where they suddenly stop working over a few months. They go from 0 to, well, actually from 60 to 0.
Right.
The adrenals slow down more gradually, and so patients end up needing more.
Okay.
More.
So how
testosterone? We haven't. We've mentioned progesterone to the extent that it can be. Another quick way of using the progesterone is actually as a. It's not a bioidentical progesterone, but it acts really well as a progesterone-based IUD. And that same.
The Mirena.
Yeah,
that kind of stuff. Yeah,
but it's a really good way for some people, and there's no increase in blood clot risk with that.
That's good. So how would you tell somebody who's listening to ask their doctor for it? What would you say? How do you get your doctor to listen? Because you are truly a unique diamond in the rough. Because you do listen. But how would you tell a patient to say, there's a patient in Poughkeepsie who's going to go to their local gynecologist?
Well,
how would you ask them to ask?
Sound them out, do you support my idea? I'm really interested in going on hormone replacement therapy. What do you think? Okay, they'll find out within a few seconds.
That's right.
Things. And if you don't get the answer, you go to somebody else.
Okay.
And there are, it's not hard to find docs who are dealing with bioidentical hormone replacement.
Yeah.
And,
okay, good.
There are lots of ways of getting it into the body.
The telemedicine aspect.
Oh, hi, Karen.
Karen, mention the telemedicine aspect.
Oh, that's true. Yeah. Is there? Do you do telemedicine, or do you recommend?
I do.
Okay.
One thing that has been really, really helpful to me, and this has happened with my experience with the vaginal rejuvenation procedures that I talked about earlier. The CO2. Now, since that time, there's more technology. It's been improved. It's getting better and better. We're treating urinary incontinence better than ever before. I'm hardly doing any surgery for pelvic floor relaxation now because we've got these other things that work really, really well.
That's amazing.
We have patients who call and they don't really know what they want. They know what they have, what problem they have, but they don't know really what they want. Or they may think they want something that wouldn't help them with that particular problem. So what I've done, and I really emphasize this because I love to do it, and it's never a wasted moment, is I offer 10-minute free phone consultations to anybody that has questions about anything that we do.
That's amazing.
And it's honestly,
are you sure you want to put that out there? Because you're going to get some calls.
I do because
okay, good.
It's and I can treat patients that aren't in the same state the way things are now. So, and
great.
A lot of these things, the lab work can be done remotely. The ultrasounds that we do for safety
can be ordered.
Remotely. So,
and you'll give me a link to that so I can put it in the show notes for everybody.
Yeah.
Okay, great.
Yeah. Karen's just shouted.
Karen's like, yeah, I'll do it.
She's got it. So that's been hugely successful of these things. So two aspects to that. One of them that's free. We'll have a conversation, and almost all of those patients end up finding somebody to do it or seeing me to do it.
That's great. That's
and
amazing.
So it's really be beneficial. The other aspect is, podcast has been great. It's a good place, and we're getting close to that magic hour.
I know.
But I don't like podcasts that go for 2.5 hours. Okay, who has that time?
Yeah, I know. Well, the people who listen to Joe Rogan, because he does 2.5 hour long interviews. No, but listen, real quick, you said phytoestrogens, and it made me think, because you and I connect and are very like-minded on, cutting out processed foods and sugars and grains. But I have heard now from multiple women who are older than me, increase your soy intake. And I am of to help with the estrogen. And I am of the mindset of that soy is bad, and it doesn't really agree with my stomach anyway. But what is your take on people changing their diet to increase soy?
It's too weak. It's not going to do the job.
Okay.
It's not, they might, there's actually no scientific evidence that any of that helps
Interesting.
and significant studies. But some people will argue that it helped them. Well, great. If it helped you, great. Not going to argue with that.
Well, then I would argue that cutting out sugar and most of your alcohol intake will also help more than taking in soy. That's my personal experience. What's that?
I said I don't want to believe that.
I know. Listen, it's so sad.
You know that.
Yeah.
No, not all of this is easy, but most of it is. This is not really complicated. It's a woman is suddenly without these hormones. Let's give them back.
Right.
Okay. Let's carefully give them back. One of the things I quickly want to say about testosterone.
Yes.
Testosterone has been abused to an extent by young males, muscle building.
Right.
And in fact, I think for older guys, it's better because longevity is associated with an increase in muscle mass. Strength is associated with longevity. And also, and so these things are beneficial, but there has been a replacement of a body that have encouraged physicians who are not gynecologists, not a lot of times not MDs, of replacing hormones through pellets, and they aren't really trained to deal with the complications. Right. And the complications that I mentioned are usually very straightforward. They're not, but you've got to know that you've got to look at the endometrium of the uterus to see if you're getting overstimulation from the estrogen. Are you is the progesterone not getting absorbed well enough to protect the uterus against that 1,000% increase in uterine cancer from estrogen alone, unopposed estrogen activity.
Unopposed estrogen, yeah.
It's so go to somebody who can deal with those things, not somebody who's playing with it.
Right. Well, I think those are wonderful words to end on. Dr. Turner, thank you so much for your time, for your wisdom, for your wise counsel. I gotta believe that you are getting together the next generation of doctors, and hopefully you're schooling them as well, because this is important information. Your work is very important.
Thank you, and it's a pleasure. And let's just spread the word. It's and honestly,
let's do that.
The other aspect is helping men through this.
Yes.
As well.
So will you please come back and let's talk about it? It can be a shorter thing because men. Yeah. No, please come back and let's talk about, because that is a legit question, and a lot of men are having their testosterone tested. I would love to talk with you about that. Right. And I just can't thank you enough, personally and professionally. And everybody, listen to the Vagina Doctor podcast. It's he has these amazing guests on. They have wonderful conversations, and I'm also on it for an episode. So please enjoy. Thank you, Dr. Turner. Thank you, Karen, in the background.
She's out there.
Yeah, we're gonna spread the word.
Anna, thank you very much.